and critical care medicine as well. And he's got an office in Oakland Park, Florida, as well. And without further ado, I want to welcome Dr. Robinson back to the program. How are you doing this evening?
I'm doing wonderful. Thanks for having me back.
And joining Dr. Robinson is Lou Biasi, the Vice President of All County Healthcare. Lou, welcome back to the program as well.
Thank you, and Doc, it's a pleasure being with you.
I'm happy you're here. We got lots to talk about.
Yes, we do.
So what is, Dr. Robinson, what is the one lung ailment that you see the most of in your practice?
Well, I'd say all the obstructive lung problems, so COPD, asthma. We have some folks with some fibrotic processes, some scarring of the lung. So I think chronic illness that's related to chronic inflammation is generally what we see.
And you mentioned COPD, and that's been a topic in the news. It seems like, every other day there's a new story coming out, new research, new treatment options. So what are some of the symptoms of this chronic obstructive pulmonary disease, or COPD as the acronym for short?
We've got kind of a symptom complex that's not too different from a large chunk of pulmonary problems. And I think that's the issue for COPD is that cough, wheeze, shortness of breath may not be specific to COPD. And so for many patients, they may go to an urgent care, they may see their family practice and internal medicine doctors for a number of years before they finally have spirometry done and make a formal diagnosis of COPD or asthma, which is also an obstructive lung problem.
Is that fall under the COPD umbrella, asthma?
It actually does. The irony is that asthma and the allergist did a very good job. I think I've joked about this many times that, it was previously a form of COPD. Well, it still is. It's an obstructive lung problem. But at the NIH, they separated asthma from COPD for research dollars. And I think that was probably the smart thing to do in the 70s because we know asthma and COPD are not the same. Even though they have chronic inflammation, they all present with cough, wheeze, and some shortness of breath or limitations with activity. They present completely different when you look at the inflammatory cascade that causes injury.
That's a good point, because just a few years ago, I work in PR, I never saw the term COPD, and until just, I want to say like the last 2 years, it's kind of been mainstream. I know it affects millions and millions of people. Now, do some of the other pulmonology ailments, lung ailments fall under the COPD umbrella, like chronic bronchitis, emphysema, pulmonary hypertension as well?
Right, so chronic bronchitis is a form of COPD. I think for most folks that have chronic bronchitis, it sometimes presents as having recurrent upper respiratory infection. A lot of patients are treated as acute infections more than once a year. And I think the infectious disease societies have told us that anybody requiring an antibiotic more than once a year generally has a chronic ailment that needs to be further managed or diagnosed. And so for chronic bronchitis, folks with chronic bronchitis, they'll generally have a productive cough 3 to 4 months or so out of a year. And we can generally track over a couple of years that these patients have had recurrent symptoms and sputum production.
And we're here with Dr. Keith Robinson. He's a pulmonologist, a board-certified pulmonologist, also board-certified in critical care medicine at Fusion Health, South Florida. I'm going to give out the info there as well. Tell us a little bit about some of the treatment options available today for COPD.
COPD has gone through a little bit of an adjustment in how we manage folks. We used to treat patients based on the severity of obstruction that we measure by spirometry, and we've discovered that from a mortality standpoint, from a longevity standpoint, meaning who's going to do well, who's going to do poorly, that using the degree of obstruction really didn't change how patients were doing. So now we classify folks A, B, C, and D. And that doesn't necessarily lead itself to a severity necessarily, but it tells us which treatments are appropriate for Class A patients, Class B patients, Class B patients, or C patients, and D patients. And I think for me, when we talk about COPD, we're really talking about 80% of the country that sits in a Class B or a Class D. So in that setting, we generally want to use a long-acting medication, something that's going to last 12 to 24 hours, something that's going to keep the stable lung function through the day so that hopefully folks aren't reaching for their rescue therapies frequently. So I think the idea that we've gone from using spirometry to help decide which inhaled therapies are appropriate means that we've now gone listening to patient symptoms, how symptomatic they are, and also how many times they've had an exacerbation or hospitalization, and deciding which inhaled therapies are appropriate.
Now, just a few weeks ago, we actually had here right on this set an IPV machine. So can you tell us a little bit about how does this intrapulmonary percussive ventilation IPV therapy work? Because I got to try it out, and I can tell you that I could definitely feel a difference. I mean, Ed Salazar, the respiratory therapist with All County Healthcare, he told me I'd feel a difference, and I really did almost like within like a minute or so of using the machine.
Yeah, I think the idea that the lung, from a physiologic standpoint, generally the airways will become wider when you take a deep breath in. But for patients with COPD, there's a large amount of scarring in the periphery of the lung, the way distal parts of the lung all the way out towards the armpits. And what we learned is that for patients with COPD, unlike asthma, where they have a large degree of muscular constriction, where the muscles narrow down the airway, a large chunk of folks with COPD have scarring in the airway that causes the airways not to be quite as open as they should, or more importantly, they have increased secretions, mucus that gets trapped into the airway, and that decreases the diameter of the airway. And when you decrease the diameter of an airway, you increase the resistance. And when you increase the resistance, it makes it that much harder for folks to expand and open up their lungs to breathe comfortably. So what the IPV device does is actually, by giving small puffs of percussive air, sends out distal or sends air out towards the periphery of the lung to help to mobilize the secretions that are trapped out of the way 16 generations, almost 24 generations out into the lung, way down the tree of the lung to help mobilize those secretions back towards a large airway so folks can cough and clear the secretions more effectively. But more importantly, and I use it in the hospital frequently, is that it allows us to re-expand the lung without actually pushing air directly into the lung, which can cause what we call barotrauma or injury to the lung. And so it gives a comfortable way to not only open up the small airway, and meaning help folks to open up their lungs and decrease their pneumonia risk, but also to mobilize secretions out of the lungs so, again, the patients are able to cough more effectively.
And do you use it in your practice as well, your office?
I do. I've got a patient who's still upset with me because we allowed you to borrow it the one show that the Parks were here.
Yeah, we had it here, Lou. Tell us a little bit about the IPV machine and how you got into it.
I got into it about 5 years ago. Ed Salazar, who became friendly with Doc, and he introduced this unit to me as a home care agency. He says, I want to introduce this unit to you, but Medicare doesn't cover the cost of it. So most agencies, when they found out the cost of the machine, which is in excess of the thousands, and Medicare didn't pay for it, they said, no, we're not interested. They went back to the old vest therapy, which is a bulky vest that patients have to wear. It's very hard to keep in compliance. I said, well, let's try one machine. We'll try it basically because we want to see how it worked and how the patients reacted to it. That's prior to me meeting Dr. Robinson. So we got a machine, and we tried one machine, and before you know it, we grew to 5 machines. It was working so effectively. And, I just had a meeting today with some accountants from BD&O who specialize in healthcare, right? In healthcare management, healthcare, et cetera. And everything we see now in healthcare, everybody says we want to cut costs. Everybody's cutting costs. Well, I think Doc will verify this. One of the biggest costs of hospitals today is the readmissions of COPD.
Absolutely.
Right? So the fact is, when they tell you they want to cut costs, right, sometimes I can't believe them. Because if you have a program that can cut your cost and say, give us a carve out, Mr. Hospital, you got patients here with COPD, and you send them home with a nebulizer that just is not going to be sufficient enough for them. Here's the doc, he's working with them with the IPV in the hospital. Well, now we can continue that same care at home, not getting reimbursed for it now. And every time we give a mouthpiece, it costs us $100. But because we're so interested in getting the patient better, right, we experimented with it. And every patient that's been on it, Doc, as you know, including Mr. Park, I think it was here a few weeks ago, has felt 100 times better. I mean, we kept them out of the hospital up to 12 months, right?
Absolutely.
Where the readmission sometimes is within 15 days. And the average cost of readmission is $40,000, $50,000. So that means when a patient goes to the hospital, he gets discharged, if he doesn't come home with the right medication, the right order, what happens? He's back in within 15 days, 10 days, feeling terrible. So, if you look at Mrs. Bush, President's wife, she has COPD. She's tired of going back and forth to the hospital. But if she had one of these units by side her bed, she'd still be living today, probably.
And it works quick. And I think that's, again, for my folks out of Coral Springs, where I do routinely take some call, starting the IPV device for my folks, especially in the intensive care unit, really flips the script in regards to who gets better quickly. And I think for me, the idea that I can get folks who are not coughing very effectively to a point where they're clearing really quickly, and more importantly, they're getting their breathing treatments down all the way to the airway where they need it the most, means that these are folks who are getting better quicker out of an ICU, which is the most expensive part of a hospital, and getting to the floor quicker and then home quicker. So the idea is not necessarily get people pushed out of the hospital as fast as we can. It's to make sure they get the therapy they require up front so that, again, we can improve their outcomes before they go home.
The outlook that I took on it was, okay, this is a machine that traditionally was just in hospitals. I mean, that's what it looks like, and it's not very big nowadays, but it's something that years ago was just in the hospital, and now it's being able to be taken home and used in the home settings. And I think what the gentleman that was on, Mr. Roger Park, was telling us as well was a little bit about it can be combined with medication as well. This is something that can be put into the machine, and it can be used as a therapeutic, medicinal.
That's right. Now, I absolutely think that it works best when you actually give the nebulized treatment, so the breathing treatments patients are receiving, because you're accomplishing two goals, which is opening up the small airway, mobilizing secretions, but you're also delivering the medications that help to stabilize the airway. So for many of my patients, if they're on maintenance therapy, I can give their maintenance therapy through the IPV device. So again, they're not only just getting the treatment that's going to manage their COPD, but we're also managing secretions, which in some of my folks with COPD, especially my chronic bronchitis folks with more formal fixed airflow obstruction, they feel better because the resistance in their airway comes down quicker. And so they're able to get out and do more and feel like they're accomplishing more through the day.
Lou, hold that thought. We're going to take a quick commercial break, and on the other side, talk to Lou about how you can get one of these machines, and then also about to Dr. Robinson about pulmonary rehab at Fusion Health on the You and Your Doctor show.
All County Healthcare, Inc. is locally owned and operated, serving the Tri-County area, Palm Beach, Dade, and Broward counties for the last 25 years. The practice of medicine is changing dramatically. All County Healthcare, Inc. still does it the old-fashioned way, where our nurses and healthcare professionals come into your home to service your medical needs, providing you the fastest and best care possible. For more information, call 954-717-7027. And remember, Medicare Home Care is covered by Part A of Medicare with no out-of-pocket cost to you. It's your decision, and only your decision, on what healthcare agency you use. Call today. All County Home Health Care, Inc. at 954-717-7027. License 200999096. You are listening to You and Your Doctor, Living Longer and Healthier, an informative show that helps you find answers to questions you always wanted to ask, but did not have that somebody that could make a difference in your life. Call into the show if you have a question at 888-565-1470, and we will put you on the air to inform all our listeners. Now, back to our show.
And we're back on the You and Your Doctor show with Dr. Keith Robinson, pulmonologist at Fusion Health, South Florida, and Lou Biasi, Vice President of All County Healthcare. Lou, before the break, I was going to ask you, how can people get this machine in their home? Do they give you a call? They go to the website? They fill out information?
Well, first of all, we're a Medicare home care agency. And before you get treatment with us, we have an exclusivity on this unit in all of South Florida for the Tri-County area. Meaning we're the only company that has this unit in the facility that uses it. And so what you have to do is you have to get a script from your doctor. And my suggestion is if anybody's out there that has COPD or has a respiratory problem, please, I visited Dr. Robinson's Pulmonary Center. And I got to tell you, it's a state of the art. If people get bad knees, they go for physical therapy for the knees, right? So people don't think about getting therapy for their lungs. But Doctor and I had many discussions about this. And I got to tell you, if you have a disease that affects your lungs, please go see Dr. Robinson at his pulmonary center. You'll be doing yourself and your family a world of good. It's the most amazing center I've ever seen. Wow. He gives you enough activity there that you'll say, geez, I never even thought that, it's only three right now in South Florida?
There are three credentials. So Boca Regional has one, South Miami down in Miami-Dade.
And you'll see some in the hospitals, like we put one of these units in Cleveland Clinic has one of our units. Now, if Cleveland Clinic has it, you know it's got to be pretty decent. Shands, I think, has 5 up in Jacksonville. So all the leading hospitals have this major unit into the facility, but they also have their outpatient pulmonary lab, okay? Doc has an outpatient pulmonary lab. He takes your insurance. If you don't have insurance, it's worth even paying cash for because you'll feel like $1 million. There's nothing more important than your health. I had a couple of gentlemen in from BDNO today, which is a large accounting firm, And one of the gentlemen told me how bad his father had it.
Really?
How bad his dad had it, and he sees how it's suffering. It's a debilitating disease, right? You're never going to cure it, and he didn't realize that we had this unit out there. And, it's very hard for us, Doc, to convince people that we cut the cost. If you can have something that reduces your hospitalization cost, why don't you do it? So I'm getting to the believe now that people don't even want to reduce their cost anymore. I think it's a bunch of bull, right? You look at certain doctors, and I should say this here, but you get these ACOs and these MSOs, it's all a cost cutting. But if you have something that can save a patient from being readmitted, we can cut your readmission pays 20-30%. And the average readmission, I think, is about $40,000.
It is right, $30,000 to $40,000. Absolutely.
So, I say something's out there. Ask your doctor. Your doctor probably doesn't know about IPV. And, tell them about it. You saw it on the program. But please, give Dr. Robinson a call. If you have COPD, and I've had patients that have called Dr. Robinson, including Mrs. Parker, Mr. Parker went down there, and they absolutely told you how wonderful it was, right? Here's a man that really had a tremendous fear of dying because he couldn't breathe, right? Now he feels 100 times better. His wife's an RN, a nurse. So my answer, if you have a problem, call Dr. Robinson. Give Dr. Robinson's number again.
Dr. Keith Robinson, pulmonologist at Fusion Health, 954-900-5635, or fusionhealthsouthflorida.com. Great website. It's where I got all the info to prep for this show. Tell us, take us on a little virtual tour through Fusion Health. It's a pulmonary rehab, correct?
It is. And, so most pulmonary rehabilitation centers that you hopefully will get to will accomplish hopefully 3 goals. One is improving exercise capacity. The whole point is that, when folks have limitations in their activities of daily living, they don't do very much. They sit around the home, which is the thing we try and counteract when we send folks and have folks come see us in pulmonary rehab. The other thing is that, we want people to understand their COPD. What is it? What is it they're living with that, again, the fear that goes along, the anxiety that goes along with not being able to catch your breath is minimized. And then the last thing we want to do is to really start working on we call them psychosocial issues, which is a lot of folks have maybe lost a loved one, and so they're on their own. Or maybe they have loved ones that are on the other side of the country, and so they don't have assistance. And so I think what we learn in pulmonary rehab is that when we add a social aspect to the rehabilitation, patients feel like they're accomplishing more than just going to rehabilitation, but that they're actually starting to have group sessions where they actually can talk about the things that COPDers live with. And it's not just for COPD. We've got folks with pulmonary fibrosis that come to us for rehab. Again, I train at a pulmonary vascular center, so we have some folks with pulmonary hypertension that come and meet with us. So the idea is if you've got a pulmonary condition, your exercise capacities are minimized and not where they should be, we can show folks exactly where they need to get to in order to get back to feeling active through the day.
Yeah, a team-centered approach.
It is. I think we added with a physical therapist and occupational therapist, because I joked with you at the opening that for many of our folks, they felt like they had to go to 4 or 5 different locations to get one thing accomplished, which was to feel better through the day. And so we put everyone in one office location. So we've got the physical therapist and occupational therapist with us in office. We had some folks, unfortunately, with substance abuse concerns. So Dr. Lear is our addictionologist, and I think the idea that we help people with their opioid concerns or other substance concerns means that, again, we're trying to accomplish more than one goal. The goal that we're really trying to accomplish is getting folks to a point where they feel like they're accomplishing getting better, not just waiting for bad things to happen to them.
And also share with us, I know you can't say too much about it, but National Institute of Health research grant this fall for pulmonary rehab, and a little bit about a gaming system, and you're going to be looking for, I guess, people for this program.
Yeah, we're part of an NIH grant. One of the few centers we're actually partnered with Carolinas Health and a gaming system, Blue Marble out of Irvine, California. And we'll be studying a gaming system to deliver pulmonary rehabilitation, not in our center, but from home. And I think that's the one thing that we unfortunately have to combat is getting patients in the front door. But I don't want folks to be at home and not get the same benefits of rehabilitation. And so the idea behind the system that we're developing is to be able to have folks get the same level of care that they would receive in our office, but receive it at home. That's
thinking outside of the box for sure. And that's something that, taking it to that level to spark people's interests and to staying on a pulmonary rehab program. Because I know from interviewing people who've been in programs, they really like that camaraderie, that team-centered approach. And even if you're engaging them, when they're not at the pulmonary rehab through like a gaming system or something, that's huge as well.
Well, we wanted to make sure that we were helping people to remember that the reintroduction to life involves changing your behavior. And I think that's a huge part of pulmonary rehabilitation, is reminding folks that if they got 2 air sacs left in their lung, they're breathing. And more importantly, if they're able to breathe comfortably, then they're going to be able to hopefully change the sedentary behaviors that leads towards bad outcomes, and get off the couch and get out the front door and start accomplishing living.
Definitely. And as a pulmonologist, what age range of patients do you treat?
I have some adolescent medicine background, and so for me, I'll see folks down as young as 12. I think for me, reliably, since I'm not a pediatric pulmonologist, I try not to see children under the age of 12. Most kids at least the age of 12 are going to be old enough to dose their medications. But I see folks from, I say 12 all the way past 100. So I don't really have a narrow range of folks that I'll see in the office.
Pretty much adolescent all the way up. And you mentioned briefly, so this is where you're fellowship trained in pulmonary critical care medicine, but you were in a pulmonary vascular program. I've never even heard of such a thing.
It was unusual to learn obstructive lung disease by learning the lung through a vascular side. So I think UC San Diego, where I trained, is world known for its pulmonary vascular center, managing folks who've had chronic clots within the lung, managing folks who have more formal, at least what we call primary pulmonary hypertension, which is in many patients causes them to have increasing shortness of breath and heart failure associated. And so I learned how to treat and manage folks from an obstructive lung problem by learning from the vascular side, not the airway side of the lung. But it helped me to realize that the lung is really 4 organs. It's not just one. And so when I really try and treat patients, I really try and focus on which part of the organ system that's causing their shortness of breath, so that, again, we can treat it and, more importantly, get them to a point where they're feeling and breathing comfortably.
Before I've had you on the show, I didn't know it was all connected in that way. The pulmonary hypertension with the congestive heart failure, and how it can just kind of blossom into a whole bunch of different issues if you don't have it taken care of. Well, we only have about 2 minutes left, but Dr. Robinson, I want to thank you again for coming on the show. It's fusionhealthsouthflorida.com, ton of info there. And Lou, I didn't know if you wanted to add something here at the end.
Yeah, I just want to keep reminding everybody again. This is not a curable disease. Am I correct, Doc?
That's correct.
But it's a disease that you can live with. In the Fusion Health, with Dr. Robinson's tutelage, I think you will feel 10 times, 100 times, 150 times better than you feel when you come in and when you leave. So, what's more important than your health? People spend thousands of dollars on cars, on food, and everything else, but their health is the most important thing. And, as I said, Dr. Robinson does take insurance. He does take cash. And I'm not promoting him, but I was at his center, and I'm looking forward to being a patient myself.
We've been trying to get you in.
All right, we're going to get in. Okay, so I think it's going to be a tremendous thing. But a lot of times, I'm gasping for breath too, So it could be my weight, it could be a lot of things. But the answer is, try his outpatient lab.
The pulmonary rehab.
That's correct. Right.
Well, thanks again, Dr. Robinson. I always enjoy having you on the show, and we learn so much.
Well, thanks for having me again.
Thank you.
Appreciate
And
it.
we'll see you next time on the You and Your Doctor show.
Thank you for letting us share with you a longer and healthier lifestyle. If you have a doctor or are a doctor and wish to be on the show, call AMP2 TV at 866-244-5422, and we will put you on the air as soon as possible. Tune in next week for more information on living longer and having a healthier life.